When we look at risk factors for Alzheimer's, there are things that increase your risk of dementia that have been formalized. High blood pressure, high cholesterol levels, diabetes, obesity. There isn't a single female-specific factor being considered in those models.
You want to know if it's menopause or perimenopause?
I want them in there.
Dr. Lisa Mosconi is a leading neuroscientist, a New York Times best-selling author, and she ranks in the top 1% of scientists in the world. She's the director of the Women's Brain Initiative and the Alzheimer's Prevention Program at Weill Cornell Medicine. She was the first to prove what women have been saying all along. Menopause isn't just a hormonal shift. It's a neurological event.
Do you see this big red blob? This is the temporal cortex, which is very close to the memory centers of the brain. And you see how it's yellow here and it's completely green over there? That's a 30% drop in brain energy levels in that part of the brain.
She's giving us an exclusive first look at brand new data from her latest research studies that could change the future of menopause treatment and brain health forever.
This is effectively the largest ever global examination of women's risk of Alzheimer's ever attempted. If everything goes according to plan, we're going to have clinical data from over 20 million women.
Plus, she's sharing the science-backed tools you need to protect your brain starting now. So what should women eat?
So the research shows...
Before we start, though, I want to ask for a quick favor. Reviews for this podcast mean everything. The more reviews, the more conversations we can bring you, and the more we're helping women take control of their lives. So wherever you're listening, please take a second to leave a review. I would appreciate it so much. I read all of them. I hope you love this conversation with Dr. Lisa Mosconi. Make sure you stay to the end because she's giving us an inside look at her most recent brain study. It's going on right now and how you can be a part of it. All right, let's get into it. Dr. Lisa Mosconi, it is always so good to see you.
Thank you for having me.
Thanks
so
for being here.
So happy to be here and congratulations.
Oh,
this is amazing.
Well, I mean, congratulations to you and everything that you are doing day in and day out, the days we don't see you.
Most of the time, right?
For women and women's health and brains and so many things to cover today. I've always loved your origin story, and I think it's really important because it shows us, where you are today. Can you talk a little bit before we get into the science, why you dedicated your life to Alzheimer's research and now in particular women's brain health?
I was born and raised in Florence in Italy, and both my parents are nuclear physicists, both of them, which is interesting. So I grew up around equation modeling, kind of.
What is equation modeling?
It's a lot of mathematics. It's a lot of physics. It's a lot of chemistry. In many ways, I remember when I was little, my parents put up a gigantic whiteboard in my bedroom. It was like the whole wall was it was a whiteboard, and we had the markers, and they would just write and write and write, and they would do my math. And then my parents would teach nuclear physics to PhD students who then transitioned to nuclear medicine, which is a branch of radiology that uses principles of nuclear physics applied to machines like scanners to look at whatever happens inside the body. And those students would come over sometimes for some additional support because it's difficult. And they would take turns talking to my parents, working with my dad, and babysitting me.
So you were being babysat by students that were studying
nuclear physics apply to nuclear medicine, hence the whiteboard in my room.
So no Barbies, needless to say.
No Barbie dolls, but a lot of machines, lots of scanners, lots of talking about the brain, brain health, how to measure things that happen inside the brain. I always thought it was super fascinating. So I would go to grade school talking about relativity, and I had no clue who Cinderella was, that kind of oddity in a way, a little bit strange, but very rewarding. So then fast forward to my PhD studies, I have a PhD in neuroscience and nuclear medicine. The apple doesn't fall too
you
far.
Better have it, right?
Yes. But at that point in time, my grandmother, who effectively was like a second mom to me, started showing signs of cognitive decline, which then turned into a diagnosis of Alzheimer's disease dementia. And just a few years after that, her two younger sisters also developed Alzheimer's disease and passed away from it, whereas their brother did not. So that was shocking and heartbreaking in so many different ways, but it was also really frightening. So my mother was really worried about her own brain health and her own risk of Alzheimer's. And so was I, honestly, because we do rely heavily on our brains.
And that is genetic?
So Alzheimer's disease has a genetic component.
Okay.
There are two main forms of Alzheimer's. There's an early onset familial form, which is genetically driven. So there are very specific genetic mutations. They're called autosomal dominant genetic mutations that cause Alzheimer's disease. And when that happens, it does run in families, and there's almost 100% penetrance, which means that if you do inherit the mutation, then it's very rare to not develop Alzheimer's. And when you do develop Alzheimer's, it usually happens in your 30s, 40s, and 50s, so very, very young ages. That's about no more than 2% of the total Alzheimer's population. So it's very, very rare. For all the other cases of Alzheimer's, they are referred to as late onset Alzheimer's disease. Usually the onset is after age 60, 65. There is no genetic mutation that causes the disease. However, there can be a familiarity. So it may run in the family, but not in a way that is deterministic, but rather in a way that puts the offspring of a patient with Alzheimer's at higher risk relative to somebody who does not have a family history of Alzheimer's disease, but it does not cause the disease. I learned that later, right? Back then, I was really worried
that had to be
about my own risk and my mother's risk. And so I started my PhD, and I really focused on Alzheimer's disease. And I would ask my PhD supervisor, who's a very good friend of mine at this point in time, I would say, does it matter if you're a woman or a man? Is it just my family? Or is there a bigger lesson to be learned?
Why did you ask that?
Because they were all women in my family. So my grandmother was one of 4 siblings, 3 sisters and 1 brother. All 3 sisters developed Alzheimer's and really passed away because of it, whereas the brother did not. And they all lived to the same age.
Being a woman put you at higher risk for Alzheimer's.
So we've known since the 1990s that after getting older, after advanced age itself, just being a woman is the second strongest risk factor for Alzheimer's disease. And now we're starting to understand better what's happening. But back then, the idea was that Alzheimer's was a disease of old age and women live longer than men. So at the end of the day, they would say to me, well, unfortunately, more women than men develop Alzheimer's disease. And that never made a lot of sense to me and to many others, in part because women don't live that much longer than men, right? Here in the United States, the gap is 4.5 years. It's called the longevity gap. But in England, for another example, the gap is 2.3 years. In Alzheimer's disease and dementia, the number 1 cause of death for women and not for men. This happens in Australia as well, I believe. So, and also if it was just aging, then women would have a higher risk of other diseases of old age that impact the brain, like Parkinson's disease or vascular dementia, but they do not.
It's Alzheimer's that we're talking about.
It's Alzheimer's disease that seems to be more specifically an issue for women than for men, which is not to say that it doesn't impact men, right? So the prevalence, the ratio is 2 to 1. So for every man suffering from Alzheimer's disease, there are 2 women. And with other disorders like depression, with the ratios kind of similar, we do have a lot of research on that. And we have medications that have been tested specifically on women. And we do understand the nuances of what depression means for women at different stages of life. For instance, with Alzheimer's, the research on sex-specific differences is really, really just starting, I would say. And there's so much that needs to happen. So that's what I've been doing ever since my PhD days.
And really leading this conversation and this research when it comes to women's brains, and in particular, perimenopause, menopause, brain scans. I mean, you really are at the forefront of this and right in the middle of some very major research right now.
The research that we've been doing, it's been over 20 years for me. I started as soon as I could, really fairly young, but What my research has shown and other people's research has shown is that our assumptions were actually incorrect. That Alzheimer's disease is not a disease of old age, but rather it is a disease of midlife with symptoms that start in old age.
What does that mean?
There's a pathology. The disease has a very specific molecular composition, which we refer to as Alzheimer's plaques or amyloid beta plaques and tangles, where the plaques basically form between neurons and impair communication between different neurons. And then these neurofibrillary tangles develop inside the neurons and disrupt the neurons from the inside. And all of these lead to neuronal loss and degeneration. Now, that happens progressively over time, and you don't necessarily feel the effect until the pathology reaches a certain threshold and the brain can no longer compensate.
This can be happening very young? What are the ages? So what ages could that happen?
Alzheimer's pathology has been noted in some people's brains as early as in their 20s and 30s. This is rare.
Do you see anything? If you were doing scans, would you see?
Yes, of course.
But you wouldn't see symptoms?
No, so the symptoms actually become evident on clinical examination when people are usually in their late 60s, 70s, 80s, and 90s. So there's a gap between the pathology accumulating in the brain, between these negative changes that occur inside the brain, and then it will take decades before the symptoms are clear-cut enough for a patient to be diagnosed as Alzheimer's disease. Do you want to see it?
I do want to see it.
You can see here that we have different stages. There's a normal stage, there's a preclinical stage, a prodromal stage, and a dementia stage. And we have two different lines. There's the gray line is for cognition, and the red line is for pathology.
And so
it's the biology of Alzheimer's disease.
Okay.
So what happens is that at the normal stage, cognition is perfectly intact and there is no pathology, right? There's no disease inside the person's brain. But then Alzheimer's plaques and tangles start accumulating in the brain, and cognition starts slowly declining. It doesn't just drop suddenly, right? And then at this point in the preclinical stage, there are individuals who do have these red flags for Alzheimer's in their brains, but they're still performing quite normally for their age and education. And so they do not receive a diagnosis of Alzheimer's disease because the symptoms are just not there. But then we reach this kind of turning point where the lines cross and the pathology is increasing, and then cognition starts decreasing to a measurable level.
And then that's when you know.
Then we have a stage called mild cognitive impairment, which is not quite dementia, but is getting there.
Okay.
And then as the pathology worsens, cognition also takes a dip.
You say Alzheimer's is a disease of midlife with symptoms that emerge in old age.
Yes.
That's different than what you were taught or what you were told that Alzheimer's is a disease of old age.
Completely different. Alzheimer's is a disease that starts very often in midlife, can start in midlife as early as a person's 40s, and then progressively accumulates in the brain, disrupting the brain's functionality, which later on leads to memory loss and issues with attention and issues with language. But see, the brain is such a beautiful organ, it's such a powerful organ that it can really hold it off for a really long time. So it can fight it.
For years and years.
For years and years. You may feel different. You may feel like your performance is not as good as it used to be. But your brain is still fighting these lesions that are accumulating. And it's only after a certain time that it's like, it's just too much.
Can you talk about how you went from while you were in the middle of research and studies and started looking at menopause and where that happened?
This is what we were doing. We were looking at sex differences in Alzheimer's. We were looking at individuals who were in their 40s and 50s and early 60s, which was very, very unusual in the field. In my field, everyone, and this is, again, like 15 years ago when I moved to New York and I started working at NYU. I was doing my PhD at NYU. The vast majority of research was conducted on individuals in their 70s and 80s who did not have Alzheimer's, which is very interesting. But like, what keeps you healthy as you age? But we were asking a very different question. We were asking, well, how far back can I actually go and realistically identify individuals who are cognitively intact, right? Their memory is fine, their attention is fine, but they do have these lesions, these Alzheimer's lesions in their brains, and we need a technology to be able to do that.
Okay.
Unfortunately, for me and for many others, the technology became available in 2007. And that was the first time ever that we were able, maybe 2006, but for me, it was 2007 here at Wellcome Leap Medicine, where we brought our very first patient to get this positron emission tomography scan, a PET scan, which is what I do for a living back from kindergarten on, right? And
from your bedroom at 6 years old.
Yes. And that was the first time that we were able to see in a living human brain what people had only been able to see a post-mortem until then.
Wow. Okay.
Yes, there was no way to get a visual on Alzheimer's pathology until 2007, which, if you think about
That's unbelievable.
It's not that long
I don't
ago.
think I didn't ever know that year. I didn't know that. I didn't know that.
Well,
that's
it was
how.
For me, 2007. I think for those who developed the technology, it may have been 2005. But still,
but whatever. It's
right?
not even, it's not even 30 years. It's barely 20 years.
It's barely 20 years, yes.
You were the first to look at women's brains for the before and the after of menopause.
For menopause. So the way that we got there is that we were using this technology, this positron emission tomography or PET imagery, to look at the brains of men and women in midlife. And what we were finding is that women tended to show more red flags for Alzheimer's disease in their brains than men of the same age.
Okay.
So then the question is why? Is it just that we're women? Or could this be in part because of things like sleep deprivation, right? Or genetics, or high cholesterol levels, or high blood pressure, or all the things that we think of as being risk factors for Alzheimer's. And nothing would really explain this difference statistically. And then one day, my students were doing cognitive testing on a midlife woman, like maybe 48, 49. And she was having a really hard time with the memory testing. And at some point, she had to stop. And she was like, can you open the window? And they were like, this is new, right? So we're in these hospitals in New York City, you can't open windows, right? And so they're like, sorry, really, I can't. Would you like some water? Would you like to take a break? She's like, I'm just gonna need to reschedule. And they were like, what's happening? Are you okay? Do you need food? Are you gonna faint? And she's like, no, I'm just having hot flashes. I can't think straight. And but it was like, you're having what? No one, these are students who are in their 20s.
Sure.
They had never heard of hot flashes, right? And so she left, and they were like, we reschedule, everything is fine, don't worry. And then they came to me in a panic, like, I'm so sorry. She left, she was hot. It was something, she was having hot flashes. So like, oh yeah. And so I explained what menopause is and how women who are going through the menopause transition, which is often before age 50 to everybody's amazement somehow, right? That can lead to hot flashes, night sweats, insomnia, anxiety, brain fog. And then I thought, brain fog. And so we went back and we asked all the women in the study to work with our OB/GYN department.
Okay.
And we collected their menopause status information, right? We had women who were premenopausal, they had a regular menstrual cycle. We had women who were perimenopausal, irregular menstrual cycles, hot flashes, brain fog, and whatnot. Not all of them, obviously. And women who were postmenopausal, more than 12 months after the final menstrual period. And then we compared the brain scans again. And what we saw was premenopausal women and men of the same age, no differences. Women who were perimenopausal in men, red flags for Alzheimer's come right up. Women who are postmenopausal and men of the same age, 30% difference.
You have those scans. Can we look at those? For the listeners, we're looking at premenopause, perimenopause, and postmenopause brain scans that you've done, right?
Yes. So this is a type of brain scan called 18F, so fluorine 18, fluorodeoxyglucose, which is a marker of brain energy levels, how active your neurons are, how fast they're burning sugar to make energy. And the reason they were doing these brain scans is that Alzheimer's patients show a very typical pattern of reduced brain energy levels that is quite specific to Alzheimer's disease. So the question was, can I detect the same pattern in women who have risk factors for Alzheimer's disease, either a family history or some genetic markers, but do not have a diagnosis of Alzheimer's disease? Their cognition is totally fine. And how early on can I detect this pattern in a woman's brain? So remember the pushback that everybody was like, it's just the women are getting older? The same pushback everybody's been getting about menopause, because premenopausal women are younger on average than postmenopausal women.
How old are premenopausal women? Can we go through those stages real fast?
Yes. So
just
for
a quick
as long
refresher.
as you have a menstrual cycle, you're premenopausal pretty much, right?
So that starts when you get your period.
I would say that is the reproductive stage.
Okay.
But then once you enter your 30s, 35, perhaps once you're past 35, we can start talking about the premenopausal stage. And then the perimenopause, also, you know what's really interesting? I think it's interesting for women to hear this, that the premenopausal stage is actually broken down into separate phases. There's a premenopausal stage where your menstrual cycle is totally fine. But then, as you're past 40 or maybe approaching 40, you may start noticing some changes. You know, your period may get shorter, it may get longer, it may get heavier, it can get lighter. It's a little bit more unpredictable, but it's still about once a month. That is the late premenopausal stage. And many women at that stage may start feeling changes in their mood and in their sleep, and also in their mental acuity.
So those are the first three?
Could be
first three symptoms of it.
It's been reported.
Okay.
Even though you may not have any hot flashes at that stage, but you may feel, especially sleep disruption, is very commonly reported. Now, can we completely blame our hormones for that? No. But it is something that is worth considering, because it's a little bit of your clue that your physiology is changing.
And that's your premenopause.
This is premenopause.
That's not even perimenopause
It's not
yet.
even peri.
Okay.
Sometimes, for some women, it's still at the premenopausal stage when your cycle is still regular. Then you may, most women go through the perimenopausal stage, which is also broken down into subphases. So there's an early perimenopausal stage where your cycle, you may skip your cycle by 1 or 2 months, but no more than 3. And then there's the late peri stage, which is potentially the worst. That's when you skip your cycle more than 3 months at a time, but you still have once every year, one a year.
You're still kind of getting your period. You think it's gone away, but it's still there.
Yeah.
Yes.
It's kind of still there, but you're hoping it might go away eventually.
You're hoping it's going to be 12 months.
And that's when the hot flashes tend to be most prominent, and the sleep disturbances and the mood disturbances and the brain fog and the attentional issues and the low libido. That's usually the late perimenopausal stage.
So when we're talking about all these symptoms we always talk about, it really is a late perimenopausal stage.
Yes, prevalently,
Okay.
most prevalently. And that is the stage that can last up to 7 years. You know, it could be as quick as 1 or 2 years.
Okay.
But it can last several years for some women.
Wow.
And it's
Okay.
usually the most challenging from a neurological perspective, right? These are brain symptoms. It's not just that your cycle is wonky, but the symptoms that come from your brain, not from the ovaries, are disruptive, can be disruptive at that stage.
Is that what we call brain fog?
Clinically, we refer to brain fog as mental fatigue or cognitive fatigue, and more technically for us in the memory space, it's referred to as subjective cognitive decline, because you experience a decline. But if you come to me for testing, you're still scoring within normal limits by age and education, which means more or less for many women who are going through menopause, there is a little bit of a dip in cognitive performance and mental acuity, but it's still within normal limits. So it is not a deficit. And I think that's a really important distinction to make, because so many women really worry that they may be losing their memory or that they may be at the early onset stage of Alzheimer's. So they're really worried about not functioning. So I think it's important to say there's a difference between something that is really impactful and demanding for you cognitively, but there's a huge difference with the dementia diagnosis. So this is not a deficit, it's not impairment, it's a subjectively reported decline.
But it's scary. And so if you don't, so how do you know as you're going through the course of your life, whether or not, hey, this might be something normal that happens, or is there something more serious going on? How can you put your mind at rest?
We started the Alzheimer's prevention program at Weill Cornell Medicine because we were specializing in Alzheimer's prevention from every different angle. So the research, the clinical practice, and the clinical trials unit. And more recently, we started reframing some of our workup, our diagnostic and clinical workup at the clinic to really address this question, because we realized that a lot of the people who come to us are actually midlife women who are going through menopause and may have a family history of Alzheimer's or some ties to Alzheimer's disease, and they are legitimately panicking because they don't know. They just don't know. Is this something just temporary? Does it go away? Or am I on the road to work? So it's really important to do a good differential diagnosis right away and to look at all possible confounding factors. Like, do you have thyroid disease? That can give you brain fog. Do you have an infection? That can give you brain fog. We had a patient who was working with us for many, many years. And then 1 year, she comes in with a diagnosis of mild cognitive impairment. And we're like, what just happened? She was totally fine a year ago. It's unusual. And so they sent her to us for more thorough evaluations. And then our study physician realized, I don't know how she did it, but she had this patient take a urine test, which is something you don't do as a neurologist. Let me tell you. She was like, let me just check. And she realized that the patient had a massive silent UTI, urinary tract infection. She had no symptoms. She didn't know she had it.
Which is very common.
Which is very common in menopause, right? She had just turned 52. And she got on an antibiotic course. Everything resolved. We got her tested again. Her cognition was right back to normal.
That is so scary.
Yes. It's exceptionally scary.
But thank goodness that's what it was.
That's something you just treat. So there are many different reasons that a person may have this feeling of brain fog. One of those being menopause. Now, we know that up to 62% of midlife, peri, and postmenopausal women report a decline in memory, attention, and language performance, which can be exceptionally scary.
Yes.
And can range from very mild to, something that you do notice in conversations. Right? So for those women, it's really important to realize it could be just menopause, if you will. Otherwise, let's do other testing. And we always recommend getting a good baseline, because then if things improve, great. But if things do not improve or get worse, then you have your own brain and your own body to refer to in terms of, we don't want to compare you to other people your age necessarily. We want to compare you to you a couple of years ago so that we can get a better sense of what's happening and why.
Do you recommend, if a woman is dealing with pretty debilitating brain fog, to come and get a brain scan?
That's what I would do. I can't necessarily recommend it because it's been done for research.
Okay.
But there are also specialized Alzheimer's prevention clinics and memory clinics that people do have access to.
Okay.
So if your concerns are serious and if the brain fog is negatively impacting your quality of life and just your day-to-day, then for me, I would want to be tested. I would want to know, is this something that will just go away in a couple of years? Is there something I can take that makes me feel better? Right? Should I start thinking about long-term planning? I'm a very practical person, so I think it depends.
Well, I know you're a scientist.
It depends, yes.
Okay, so let's see. What are we looking at here? Because these are the scans that you did.
Here's the thing that people would say to me: well, whatever you see in women who are after menopause is just age, because they're older than women who are premenopausal. And they're like, yes, but I'm matching them to men of the same age. If it was just age, then the men would show the same things. They're like, no, because they're men. I was like, okay, you know what? We now have women who are exactly the same age. These women are all 50 years old. This woman has a regular menstrual cycle. This woman is perimenopausal, skipping periods. And this woman is postmenopausal, early postmenopausal, just a few years after the final menstrual period.
And can you describe what we're seeing in each one?
Yes. So these are brain scans done with FDG PET, which is fluorodeoxyglucose positron emission tomography. And we're looking at brain energy levels. We're going to look at the premenopausal woman first, where you can see a lot of red. There's red at the top of the brain, to the side of the brain, and here in the middle at the bottom. This is exactly what a healthy brain looks like from a metabolic perspective. You want to have a lot of red, some yellow, and just a little bit of green in the middle of the brain, which is perfectly normal. And then we have these areas in blue, which is fluid. There is fluid inside the brain. It has to be, right? It's a cushioning support mechanism. Now, what happens at the perimenopausal stage, if you look at these lines that connect the three different brains, you can see, I think, how the red, especially here, is turning yellow. Everything is a little bit yellower than here. And then at the postmenopausal stage, there's the big drop where the red turns yellow and the yellow turns green, and everything is much darker in some ways. Can you see it?
So there's less energy.
Do you see this big red blob?
Yes.
This is the temporal cortex, which is very close to the memory centers of the brain. And you see how it's yellow here and it's completely green over there? That's a 30% drop in brain energy levels in that part of the brain.
And what does a drop in... And by the way, as we're looking at these, we're going to put a link to Dr. Mosconi's scans in the show notes, so you can take a look at her scans as well. So just be aware of that if you're listening to this. Does that ever recover? What does the lack of brain energy mean? Is that where the brain fog comes? Is that where the...
We're trying to understand what this means behaviorally. And this is something that always comes up when we talk about brain scans, that people just assume that because something is happening in the brain, that would immediately translate into something that you can see in a person's behavior, or that's not always the case. This is something that happens at the tissue level, but it does correlate with memory function. So the lower your energy levels in the brain, the lower your memory, attention, and language capabilities within normal limits. So these changes are not in any way, shape, or form the sign of a deficiency. It's just something that happens in the brain as part of the transition to menopause for some women, at least. For some women, it could be something more serious. But we do believe that this is a sign that the brain is kind of switching gears. Because estrogen, especially estradiol, is a neuroprotective hormone that also energizes the brain. And if you will, it kind of pushes neurons to burn sugar faster. Okay. It's like estrogen is almost to the brain what fuel is to a car, what gasoline is to a car. It gives you that extra, speed, right, in a way. Right. And after menopause, estrogen production, estradiol production remains minimal. It doesn't completely stop from the ovaries, but levels are very, very low. And another form of estrogen is being produced a little bit more than before. It's called estrone, which is our backup estrogen, but it's not nearly as impactful in the brain as estradiol used to be. And so there's an overall change.
And so we really see, for people who are listening, we see the premenopause scan with a lot of red, a lot of brain energy. Perimenopause,
and in between.
In between. Postmenopause, we see a lot more green and blue, but not as much red, which is a brain energy. Now, does that come back after we are in postmenopause, after we've hit menopause and postmenopause? Yep. Because I have to say, when you and I first met, which is a few years ago now, I had really debilitating brain fog to a point that I'd be very nervous. I didn't feel my confidence like it used to be because I didn't have the memorization skills that I used to have. over the course of the past maybe 6 to 8 months, I felt those coming back. And I have really felt them. And I was like, am I imagining it? Am I just wanting to feel them? But I definitely feel them. I definitely feel that I don't hesitate. Right. I don't hesitate when I'm speaking. I don't feel like I need cards. I mean, I was to a point where I would put notes on the top of my computer because I would be nervous that I would forget something. And so that's very nice. But is that what happens? Is there a bounce back after you've been in menopause for a little while?
You may not be surprised to hear that there isn't a lot of research done on
Dr. Lisa Mosconi, I'm shocked by this breaking news.
Yes. So we are now following our patients over time, and the results are not published yet. But what we do find, and this is until peer review allows publication, we do find, at least descriptively, that it depends. So after menopause, there can be different outcomes. For some women, cognition rebounds. In other studies, clinical studies have shown that after the final menstrual period, there's still the early postmenopausal phase where the brain is kind of settling down, is trying to adjust. And then for quite a few women, actually, cognition bounces back. That's usually between 2 and 4, and maybe 6 years after the final menstrual period.
It starts to bounce back to where you were before you went into menopause?
Sometimes.
You don't have your 26-year-old brain again, most likely.
No.
You have to work on it.
At that point, you're also older, right? So
Sure.
It would be a lot to ask, I think, of an organ. But I think just getting to where you were before you started having the brain fog, more or less, I think it's a good thing. For many women, it just stabilizes. Doesn't get any worse, but it kind of remains a little bit lower than it used to be.
Does every woman go through these changes?
No, not necessarily. So about 62%, between 34 and 62% of women that we have surveyed, not me personally, but the field, report cognitive changes, which other scientists have shown, and we have shown too, that they are actually measurable. That you can see that if we have this test, it's called the MOCA, like coffee.
Oh, MOCA, I'll remember that.
Yeah, with a C, MOCA is the Montreal Cognitive Assessment, or the mini mental state examination, where the scores range from 0 to 30. Most women around age 40 are between 28 and 30, but also women in their 50s, more or less between 27 and 30. So if you're a 30, when you're going through menopause, you may end up being a 29 or a 28. You may then bounce back up to 29.
Okay.
If not 30, But the variability is small. However, the 2-point drop is the difference between needing notes and not needing them. For most women, cognition may either bounce back or stabilize, but for some women, it does not. And that's when we start really talking about Alzheimer's prevention and what we should do to try and either really reduce the risk of Alzheimer's or try to prevent or delay onset and progression. So there are different strategies depending on each woman. So there is no specific answer.
Okay.
After menopause, there's a lot of different factors that come into play, and they do need to be assessed thoroughly. And then an individualized plan can be made for all women. But on average,
Right.
things do tend to get better.
A majority of women, they tend to get better? Or we don't know. We don't
know exactly. I would say yes. I mean, if you look at the female population, women are perfectly functional. And actually, one thing I would like to add, we were talking about the 0 to 30, that a woman starts out as a 30, may end up being a 28. Even at the 28 level, most women still, on average, outperform men of the same age.
Really?
Yes. So I think this is very important, because I'm always worried that people may not use, but take our work to imply that midlife women are underperformers. So I would love to point out that there's many studies using cognitive testing showing that even though your cognition may be a little bit less effective than it used to be, you're still pretty much the same as a man of your same age who's not going through menopause.
Why is the information not widely known that menopause affects the brain?
I think in part historical reasons, where what we call sex hormones are actually mislabeled as such, because hormones like estrogen, progesterone, testosterone, those were discovered in the 1930s by scientists who were studying reproductive function.
Okay.
And so when they discovered them in the reproductive organs, they understandably labeled them as sex hormones. And we've been stuck with that definition ever since. It was only in the 1990s, 1996, the scientists at Rockefeller University discovered that the same hormones that are important for reproduction are also really crucial for the functioning of our minds. And so now we don't say necessarily sex hormones, they are neuroendocrine hormones.
Okay.
Which means neuro, brain, and endocrine hormonal reproduction system. So estrogen, progesterone, testosterone, those are brain hormones too. We just don't talk about them that way. And then what happens, again, because of historical reasons, is that whatever is reproductive is somehow managed by a reproductive health specialist, right?
An OBGYN.
An OBGYN. So if you go through menopause, if you're pregnant, if you have any issues around puberty, you go to a specialist who will look at your reproductive function, but not necessarily your brain function. So there's this distinction in a way, there's this disconnect between what transition states are, the 3 Ps, puberty, pregnancy, perimenopause, and how we manage them clinically. Because so the best definition I've ever come across for menopause, you know how people try to make sense of menopause. And some will say menopause is a pathological state. Some people even say it's a disease. Textbooks will say it's a state of estrogen deficiency caused by ovarian insufficiency or failure. And it's very negative, very, very negative. And then there are so many scientists who are like, wait a minute. This is a normal, which I think is not the best word necessarily, but it's a physiological and natural physiological state. There's no need to medicalize it or pathologize it. And I think
meaning menopause is not a disease.
That's what they're saying. It's not a disease. It's perfectly natural. But there's the downside. There's a downside to both interpretations because one is, in my opinion, off the mark. The other one is kind of downplaying. Dismissing for women the way that they experience menopause. So I think the best definition, the most comprehensive or accurate definition is that menopause is a neuroendocrine transition state where your body and your brain are transitioning from your reproductive life to your non-reproductive life.
Your body and brain are transitioning from your reproductive life to your non-reproductive life.
Yes. So it is
That's such a nice definition because it's clear on all accounts. It takes everything into play. So you don't think it's just no periods, right? Or hot flashes. You understand brain as a part of that.
And you're also implying that if something that is genetically programmed to happen happens, that is not a disease. It's life.
Yes.
However, it does change your body and your brain. And while that transition is somehow needed, and it's, or perhaps, let's just say it's just part of you being a woman or being born with ovaries, it does have glitches. You know, it's not a smooth process most of the time. And the idea that this is a neuroendocrine transition state, which can impact your brain and endocrine system, your brain and hormone system at the same time, leading to hot flashes, leading to disrupt sleep, leading to low mood, leading to brain fog, that validates women's experience and also validates the need for medical care. Because we can't just keep suffering for something just because it's not a pathology.
Yes.
It doesn't mean that it's easy. It doesn't mean that it's inconsequential. It doesn't mean that there are no long-term consequences for some women, right? So we really need, I think, to do a little bit of a better job here.
I do too. And because I think it gets very confusing and it gets scary.
Yes.
And I think the last thing we want to do is have young women feel scared about this transition. I think we want them to understand what's happening. And so it's more predictable too.
Yes.
And I think that even though we all go by menopause differently, that they understand what the options might be, what they are, and then the solutions. Right.
Yes.
And then what we know right now. What's
really important to understand is, number one, there's no reason to be scared.
Right.
Right? And number two, there are solutions. Yeah. And there's absolutely no reason to not ask.
And it should be a bit of a celebration, too. You're the first person that told me that. And I think that we miss the mark here culturally when we make it seem so terrible part of life, because there are some real gifts of menopause, I think.
I think so, too. I find it quite unilateral and quite cultural to think that menopause may be putting women at a disadvantage. I think what really shocked me most when I started working with women who were perimenopausal, postmenopausal, was that there was absolutely no sense of accomplishment there. They would just talk about their menopause as something they had to endure, something they had to survive, something they had to fight. And they would say, that's your body. They were talking about, how about giving your body some love and appreciating everything? And I do not mean this in a judgmental way. Absolutely.
No. I understand.
The opposite, very compassionately. It's you, let's just take care of you. Let's make sure that you can navigate this transition with ease, if possible, but in a minimum with some self-love and self-care and just compassion and appreciation, I think, also for what our bodies are constantly doing for us. And I think the way that I explain it to my daughter, at least, when she's having she's 10. It's incredible. But whenever she's having a rough day, I always say, sweetheart, your body loves you. Your every cell in your body is working tirelessly to make sure that you're okay and thriving. If your body is going through a hard time for whatever reason, if there's any problem, let's help out, right? What can we do to help? And I think that's a healthier approach than resenting potentially a decade of your life when it comes to menopause, right? So you and I were talking about it. Maybe because I'm a scientist and I studied menopause, I understand how pregnancy can change a woman's body and brain. I was never scared of being pregnant, and I'm not scared at all of going through menopause. And I was joking with Kevin, with my husband. I was like, when I'm in menopause, I want to party. I want a celebration. When I was pregnant, I had balloons. Yeah, I had baby showers.
I'm going to give you a party. Thrilled. I'm going to give you a party. You just need to tell me when.
Yes.
But we did have the world's hottest menopause party.
Yes.
It really, I really think that must have stuck in my brain when you said that. You said, when you're pregnant, there's a party. When you're period, your period, you celebrate.
Through puberty, my parents got me a gift. I was like, for what? I was like, it's a big day. You're a woman. I was like, sure, I'll take it. But then women go through menopause, and this says just maybe let's just not even talk about it. You're almost ashamed, and that is not right. It's not right. I think women really can endure so much, right? I think if women were not part of society would fall apart. We carry so much water at every stage of our lives. And if we do have a bit of an issue, the least the society can do is help out and give back.
Yes, and yes. And that's why I always want to make sure it's never used against us at this age, and never. And so the understanding is understanding that it's a time in your life, and that women come out, I just really think, wiser and stronger on the other side of that. And I think if they know what they're going through, it's an easier transition, no matter how debilitating these symptoms can be. And I never want to underplay that. And hot flashes can be debilitating.
Absolutely.
They're not a funny thing. For some women, they're depression, insomnia, not sleeping, all of those things, hair loss, they're real. They're really real.
And your self-confidence can also be negatively impacted by that. It's not just the actual symptoms, but it's just how you feel. Like you said before, I don't feel like myself. That's horrible.
It is horrible.
Right?
It is horrible.
To not feel in touch with yourself or not happy about yourself and your life. So I think it's important, just knowledge is obviously power, but then action is really what tips the scale, is what makes a difference.
If there's a woman listening to this right now that feels like she is losing herself.
Yeah, or losing her mind. That's what I wanted to tell you. So many women come to us because they're terrified that they're losing their mind. So if nothing else, the brain scans and the research that we've been doing, I would say they really validates what women have been saying for centuries. That something is changing, that menopause can change your brain in ways that some women actually notice. And if if I may, there's one concept that I would love every woman to be aware of that we don't talk about enough, which is the concept of hormonal sensitivities.
Okay, explain that.
Hormones alone don't matter that much, to be honest. Hormones are like information carriers. They're like messengers. They're chemical messengers. They need to convey the information to someone else. The someone else being a receptor. So receptors are these little structures that are pretty much in every organ system in a woman's body, for estrogen in this case, that bind to the hormone, read the information from the hormone, and then use the information to talk to your DNA.
Okay.
And tell your DNA, we need more energy. We need more protein. We need more anti-inflammatory markers. We need more antioxidants. We need more blood flow to your brain. We need more synaptic plasticity. So women's brains and bodies are born with a lot of estrogen receptors. Our brains in particular are wired to respond to estrogen because of all these receptors that are really calling for estrogen. Can't wait to grab some estrogen, right? So the density and functionality of our receptors is also a little bit different. What does that mean? That maybe I have premenstrual anxiety before my menstrual cycle and you don't. I'm not saying that I do, I don't. But just for an example, different women react to hormone levels and changes in hormonal concentrations differently depending on a number of factors. But every woman is different, so there's a range of response to hormonal changes. And that means, for instance, that women who are pregnant, or actually the postpartum stage, for some women is wonderful. There are no mood changes. For some women, there's a little bit of baby blues. Some women have the postpartum depression, which can be very debilitating. And rarely a few women can experience something very extreme like postpartum psychosis, right? This is because of hormonal sensitivities. Every woman reacts differently to the same type of hormonal change.
In your brain or all over?
All over.
Okay.
But it's more evident, I think, in your brain. Like there's a whole range of depressive symptoms. There's women who do have brain fog, women who don't have brain fog, women who have a little bit of forgetfulness, and women who may develop Alzheimer's at the end of the line, right? And the same with hot flashes, right? 30% of pregnant women have hot flashes.
Right.
And there's a high chance that if you have a hot flash during pregnancy, you may have more as you go through menopause.
There's so many things that we're still understanding. It's fascinating to me. It really is.
All these P's, the 3 P, puberty, pregnancy, and perimenopause, they're basically a stress test on your brain and body.
Okay.
It pushes your brain and the rest of your body to function under stress. And that's when you can get a sense of your future risks.
What are the future risks you can get a sense of?
Like for instance, if you have postpartum depression, you may experience depression again as you go through menopause.
Okay.
If you have hot flashes during pregnancy, you may have hot flashes again during menopause. If you have anxiety when you're pregnant or after pregnancy, you may get more anxiety or anxiety again as you go through menopause. It's a continuum because it's the same system.
Because your body is, it's the same body.
It's the same
and it's
body.
reacting to the same loss or gain of hormones.
Yes.
Can you talk about menopausal hormone therapy and possible Alzheimer's prevention or menopausal hormone therapy and how it's helpful to your brain?
Hormone therapy, as we all know by now, has a very tortured history where at first it was kind of seen as this magic bullet that every woman should take for life in order to be healthy and beautiful and feminine and live forever almost, right? And then the NIH stepped in and said, well, we need to test whether hormone therapy can do all the things that it's been prescribed for, which is not just relief of hot flashes, but also prevention of cardiovascular disease and dementia. This was back in the 1990s when the NIH launched the Women's Health Initiative. Now, as I mentioned before, the fact that estrogen and progesterone are also brain hormones was discovered in 1996. But the Women's Health Initiative launched in 1998. So scientists back then barely had any information on the mechanisms of action of these hormones in any organ but the ovaries and other reproductive organs. So that's important to know. So it's hard to say that the Women's Health Initiative was a disaster. I would say that it was extremely futuristic in what they were trying to do, because they really talked about prevention when no one in my field would do it.
They were trying to figure out whether or not hormone therapy
could prevent Alzheimer's disease or could prevent cardiovascular disease.
That's what they were looking at in that study. And that is the 2002 study that, by the way, we've talked about quite often on this show, which was called the Women's Health Initiative. And the study was started in the 90s?
Late 90s,
Late 90s, and then that released in 2002, or actually halted in 2002.
So the Women's Health Initiative had two arms. Because something that's important to know is that you can take different types of hormones depending on whether or not you have a uterus. So women who undergo a hysterectomy, they have the uterus removed surgically, they can take estrogen alone. They don't necessarily need to take a progestogen with the estrogen. Why not? Because estrogen alone stimulates cellular proliferation in reproductive organs, including the uterus, which has been linked with an increased risk of endometrial cancer. So then you take a progestogen, which could be progesterone, which is the same type of hormone that the ovaries make, or you can take a progestin, which is a synthetic molecule that looks like progesterone, but not quite. And that brings down the cellular proliferation effect, effectively minimizing the risk of endometrial cancer. So if you don't have a uterus, you can just safely take estrogen alone in that sense. If you do have a uterus, you want to take a progestogen together with it. Now, back then, all the women in the Women's Health Initiative were taking a very specific kind of estrogen, which is called a conjugated equine estrogen, CEE. CEE is not so much estradiol, but which is the boss in the brain, is more like estrone, which is the backup plan in some ways.
The backup one.
And it was taken orally as a pill at relatively high doses. Then there was another arm in the study where women with a uterus were taking the conjugated equine estrogens, but also a progestin, a synthetic type of molecule that looks like progesterone, was called MPA. Those are the only types of hormone therapy ever tested in a clinical trial of Alzheimer's prevention.
That is not what we get today.
That's not what we get today. So that's, the CEEs are still in use. The estrogen. The MPA, it has been mostly discontinued because it's been shown to increase the risk of vascular damage. Among also because we have better options right now. Again, this was like late 90s. Right? So then what happens is that in 2002, 2003, the Women's Health Initiative was stopped because the trials showed a higher risk of cardiovascular disease and dementia in the group of women who were taking estrogen with the MPA. Right? Not in the other trial. So when it comes to Alzheimer's disease, for women who were taking estrogen only, there was no protective effect, but there was no harmful effect statistically.
So it didn't do any, it didn't
pretty
make
much
a
it didn't do
difference.
anything. For the women in the, it's called the combined therapy, there was an increased risk of dementia. Something that is really, really important to say is that these women, besides taking formulations that we no longer routinely use, were also at least 20 years postmenopausal, right? So they were mostly in their 70s and 80s. That is too late because if you remember, the hormone alone doesn't mean anything unless there's a receptor that's ready to use it and to connect to. So what happens in the brain after menopause is that because the hormones are just not there anymore, and I'll show you the brain scans, but the brain kind of stops making these estrogen receptors. They're not just a permanent feature in your body. They're an active mechanism. And your body only makes them if there's a reason to make them. There's estrogen, I need the receptors. If so estrogen is gone, the receptors may be gone.
So
right?
the age was wrong.
The age was wrong. Now, the catch-22 when it comes to Alzheimer's is that it's impractical to start a clinical trial that looks at using hormone therapy now for menopause and then wait 20 years for some women to develop Alzheimer's dementia, to have a diagnosis of dementia. So that's never going to happen. It's just not possible. So we don't have any.
So we don't have that research.
We don't have any. What we do have is observational evidence, including really well done studies, very large scale. And what you need to do with observational evidence is called a meta-analysis. It's a statistical integration of all available data, with any data you want to do, but especially with observational evidence. And this is our meta-analysis, includes more than 6 million women. And it shows something that I think is quite clear. So this is women without a uterus who are taking only estrogen. These are the women who have a uterus and take estrogen with any type of progestin. Now, for women who are using only estrogens and they take it at the right time, within 10 years of the final menstrual period, there is a significant risk reduction for Alzheimer's disease. So these women have, on average, a 32% reduced risk of Alzheimer's disease and dementia in old age, relative to those who don't take hormones. If you start taking hormones, in those studies at least, more than 10 years after menopause, then there is no protective effect. It's neutral.
So that's where that 10-year window after you've hit menopause comes into play. And
for the other type of formulation, estrogen, for women with the uterus, if started in midlife or within 10 years of the final menstrual period, there's still a 23% reduction in Alzheimer's risk, which is, however, a trend level, which means that some studies show a protective effect, but other studies do not. They may even show a harmful effect. And what we have found just recently, it is published, so I can talk about it, is that all the studies reporting a negative effect are from Northern Europe, which is very interesting.
Not the US.
Not the US. So I wonder what was happening in Northern Europe in, a long time ago when these women were on hormones. So these are the studies in blue show a protective effect. Those in red show an increased risk of dementia. So the whole North America is blue.
Protective
effect.
What year is this from?
Now.
Oh, this is now.
Yes.
Okay. Well, so when somebody says hormone therapy is very confusing to me, should I consider it to protect my brain in menopause if I'm within 10 years or if I'm in perimenopause?
Yeah. So this is research, and I think it's really, really important to clarify what has been done for research and how much research we actually need for any finding to become something clinically useful. There is obviously a disconnect. So we do now, we published this in 2025.
Okay.
For context.
Yes.
This is new. So we do now have some coherent evidence that there may be situations where starting hormone therapy, especially estrogen only, for women who go through surgical menopause in midlife may be protective against Alzheimer's. Is that enough to make it into clinical guidelines? No, because this is observational evidence. We need stronger evidence for a protective effect.
To say 100%.
Yes, clinical trial evidence would be amazing. We can't do clinical trials of hormone therapy started in midlife and then wait 20, 30 years for someone to get Alzheimer's. What we can do is use a modern approach to this question, where we look at menopause hormone therapy now, and then we use brain imaging and other biomarkers to see if women develop the red flags for Alzheimer's relative to those who are not on hormone therapies, and if this treatment can slow progression or prevent onset of disease. It is now in clinical guidelines that for women who go through menopause early or prematurely, which is before age 45, and for surgical indications such as an oophorectomy with or without a hysterectomy, then hormone therapy is actually recommended for a number of things, including support of cognitive function, which is not the same as Alzheimer's prevention. However, is really in the right direction. Yes.
Is this the first time I've seen this study?
This one here?
Yeah.
Yes.
When was this?
2 months ago, 3 months ago.
This was just released? So
Yes.
this is the first time?
Yes.
This is really exciting.
Mm-hmm. And we also found an effect of ApoE genotype.
What is that?
ApoE4 allele or genotype is considered a risk factor for Alzheimer's.
Okay.
And we do now have some evidence that hormone therapy may work better for women who do not have that specific gene. However, that is from the observational data. So there are studies using biomarkers that show a protective effect also for ApoE4 carriers. So I think this is important to know because some women have been discouraged from trying menopause hormone therapy for cognitive support because of this ApoE4.
I mean, I think this is such encouraging news and starts to move us into a direction where we want to ask more questions about it.
Yes.
And I know you're doing more research on it. What does science say about food and brain health?
For decades, science was saying that food had no impact on brain health. But then science also said that exercise had no impact on brain health, that air pollutants had no impact on brain health, right? And now they're all part of guidelines for Alzheimer's prevention. So we do know that food is not just food. Food is information. So the nutrients that are present in the foods that we eat are actually chemical molecules that have a direct impact on your body, sometimes even at the cellular and DNA level. So for instance, we all talk about omega-3 fatty acids, right? It's something that's good for your heart, it's good for your brain. But the reason being is that this kind of fats have both nutrigenomics and nutrigenetic effects, which means that they enter your circulation, they go inside your cells everywhere in your body, and they speak directly to your DNA, saying, I'm here, I'm an anti-inflammatory, things are going to be great, and then your body adjusts accordingly.
So what should women eat? What should women eat?
So the research shows that for women, especially at midlife and also older age, a predominantly whole foods-based diet with reasonably abundant amounts of vegetables and fruits and plant-based foods, that's really been linked to better health and better outcomes overall.
Especially in perimenopause, menopause, postmenopause years.
So there's one study in particular that I thought was really well done out of England, where they looked at really large data sets and showed that women who consumed healthier overall diets with minimally processed foods and good amount of fruits and veggies, but also fish and legumes, tended to experience a later onset of menopause and milder symptoms as compared to women whose diets were richer in processed foods and refined sugars.
So there a food that can delay menopause?
That's an association, but many studies have shown that there is protection. So the more foods you consume that are high in antioxidant nutrients, in anti-inflammatory nutrients, in brain-supporting nutrients, in heart-supporting nutrients, and the overall healthier you're going to be, right? In part because we tend to eat about 3 times a day, every single day, right? So we have multiple chances every day to make a smart choice and really nourish our bodies and our brains, or the opposite. And that over time really builds up.
What is an ideal diet for women in midlife?
I'm not a dietitian, but the research, the science shows that a Mediterranean style diet has been associated time and time again with better women's health overall. And a Mediterranean diet is actually not that hard to follow. It's pretty good.
It's good. There's some good stuff in it.
It's delicious. And these are diets that really favor fresh produce that is not processed, or fresh food that is not processed at all, where fruits and vegetables and plant-based foods really are the star of the show. And then you have smaller amounts of other foods, especially animal-derived foods. So it's a very inclusive diet. It's not like a deprivation diet. There's always ice cream, once in a while. There's always like a nice treat. But then the treat is homemade. Your mom just baked it, or your grandma just made you a a pie or something. So you don't eat the whole pie, you eat a little bit. So there's an eye on portion control, there's an eye on making sensible choices and nourishing your body from the inside out.
How do you feel about alcohol with the brain? Is there a correlation there, or is it something we should be aware of?
Alcohol is, by definition, the chemical functionality of alcohol is to be dehydrating.
Okay. Which is not good for the brain.
No, it's not good for the brain. So that's actually the last thing that any brain wants, is to be dehydrated, because the brain is actually the one organ that includes the most water and fluids, and that is more easily disrupted by changes in hydration levels.
So when we talk about drinking water, that's what we're talking about, is really nourishing our brain with water.
Yes.
Is that right?
Water is actually food. I would consider water as food for the brain. And I will say there is a difference between actual water and filtered water or distilled water or soda.
Okay.
Water is fluids with nutrients, right? And your brain doesn't just want something wet. It wants fluids that include nutrients like electrolytes and salts and minerals that are really important for brain function. Water is essential for every brain functionality, every reaction in the brain to occur. And you don't want to be dehydrated for a number of reasons, including that the brain is sensitive to a very mild dehydration, where 2 to 4% water loss, which is just sweating, may, for some women who are sensitive, may lead to symptoms like dizziness or headaches or fatigue or even some kind of brain fog. Mm-hmm. That is very easily reversed by just drinking some water throughout the day. So I would say soda is not water. Filtered water is not water.
Coffee
Purified
is not
water is not water. Oh, coffee. Coffee is caffeine with water. No, it's not really water. No.
So you have not shown this study anywhere. Is that right? This is a new study.
If I have not seen it to you, I have not shown it to anyone. So it's got to be new.
Okay.
All right. So we did a meta-analysis that we talked about. This was 2024, I think. And we had a lot of questions, and people reached out with a lot of questions about specifically this variability that we see. And also, after we published this meta-analysis, there was another study that came out from Denmark showing that hormone therapy use in midlife, the estrogen-only therapy, was actually associated with a higher risk of Alzheimer's and dementia. And that, of course, was like all over the news.
I remember that.
Number one, let's do an update of the meta-analysis, including this new study that's scaring every woman off taking hormone therapy. But also, I was telling my students, I was like, this is another study from Northern Europe. I am seeing a pattern here. Can you test if that is correct statistically? Is it just me, because I'm a little bit irritated right now? Or is there actually an effect of where the hormones are being taken? And so we did a follow-up analysis that includes all the available data up to now, and we still find a protective effect of hormone therapy taken in midlife within 10 years of the final menstrual period against Alzheimer's disease risk. But then my statistician called me back and said, you are right. There is an effect of location, because there's a lot of variability in the data, and you always try to explain what is driving the variability. Why is it that some studies are showing this, and these 3 studies are showing that, and this stuff? What do these studies have in common that could give us a little bit more of information? And there is an effect of geographic location. So this is any form of hormone therapy.
Okay.
And risk of Alzheimer's disease. The countries in blue are all the countries that ever published data looking at associations of hormone therapy and Alzheimer's incidence in late life, showing a protective effect. So that's all of North America plus some parts of Southern Europe. That's Italy, the little one over there. The countries in red, which as you will notice, they're all in Northern Europe,
yes,
show a negative effect.
So studies from Northern Europe more likely to report adverse effects in other locations.
Yes. And when you do something...
Is it a different type of hormone therapy?
So in some ways, yes. They would use, it's not the estrogen so much as the progestins that are being used. They tend to be more the kind of progestins, which is a synthetic molecule that looks like progesterone, but it's not quite, that we use for birth control. I don't want to scare anyone out of birth control. It's used differently in this case. And somehow that kind of combination has been linked with a higher risk of Alzheimer's. However, I just want to point out again that these studies are looking retrospectively at women who did start taking hormone therapies in midlife but 20 years ago, 30 years ago, and are now old enough that some of them have dementia and some do not. Okay, so it's not the same as a clinical trial where everybody starts at the same time and we know exactly what they're doing, because some problem I have with this kind of studies is that, there's 20 years in between. Are we accounting for everything that's happening in those 20 years? Do we have data for those 30 years?
Everything is changing over the course of 20 years, environmentally, everything.
Yes, there's so many things that may have gone wrong that are not accounted for in those studies. So we need to do research differently. We need to do research in a way that is proactive. We need to do research on menopause hormone therapy in a way that is fresh and modern. We can't rely on data when women were taking the hormones before the Women's Health Initiative even stopped.
I think it would be safe to say you don't want women to feel afraid of hormone therapy.
No,
because
absolutely.
There are some very protective things about it.
I think the guidelines are quite clear that most women are scared of breast cancer. And now clinical guidelines are really, really clear, stating that for women who are younger than age 60, which is arbitrary, it's more like an indication, but let's say within 10 years of the final menstrual period, then for women who are eligible, right, there are contraindications, but most women are eligible. For those women, hormone therapy is safe and the benefits typically tend to outweigh the risks, which is not to say the risks are zero, right? These are medications, right? So I think it's really important to put the risks and contents that you have done that with Corinne, Dr. Mann, when she was here, which I thought was brilliant. So it's important to really understand the balance of risks and benefits. But for most women, hormone therapy is safe relative to breast cancer risk. However, mammograms are really important. Screening is really important. Your family history is really important. Your oncology family tree is really important if you do have it, right? So you want to talk to a specialist who is informed. Once you're done, I would love all women to know that hormone therapy is on the table, that we can't keep listening to something that happened 20 years ago, over 20 years ago, as the only source of truth. That is not correct. We have done so much research since showing that hormone therapy can have positive effects. Some are now included in FDA regulations. Sometimes hormone therapy may be prescribed off-label for some other indications. And there's a lot of research that needs to happen on whether we can also use it for Alzheimer's prevention and brain fog. And I'm really happy to say that the research is now happening, and it's happening fast. So we should have more information to discuss really soon.
And you are heading that up.
I am.
Can we talk about your new initiative? Because you and I spoke about it when you first made the announcement, and I was thrilled to do that. But I did not have this podcast or this platform to talk to you. So that's why I'm so thrilled that we're able to do this in-depth look at everything that you've done, Dr. Mosconi, because it's been incredible. It really has. And I can't wait to see what's next. So you're a part of CARE. You're leading that. Can you explain your position, what it is? And it is going to be pretty fast, really.
We're moving so fast. And I was just telling you, just coming from a very busy couple of months. So almost a year ago, actually, Dr. Regina Dugan reached out to me. Now, Regina is like a legend. She is the former director of DARPA. DARPA is the Advanced Research Program Agency for Defense. I know many people are not familiar with DARPA, but most people are familiar with the movie Oppenheimer.
Oh, yes. Okay,
yes.
we know.
Okay. So
Ladies, if you know Oppenheimer, then we understand what you're saying. See, if you simplify it for me and for us, then it's good.
So Dr. Oppenheimer was the scientist who was entrusted by the government of the United States to put together a team of scientists from all different parts of the world to work on a very, very high risk, high reward project, which ended up with the development of the A-bomb, right? The atomic bomb, and which effectively led to the end of World War II for the United States. That model, regardless of outcome, but that model was so effective that the government of the United States said that's the way the scientists should work. It shouldn't be each scientist protected their own little territory. They should work together. They should be given the funding to work together and move faster than any single scientist can ever hope to move alone, right? So that is how DARPA was born back in the 1960s. DARPA is the Advanced Research Program Agency for Defense. And Regina, Dr. Dugan, ran DARPA for quite a long time, and she's the first woman ever to run DARPA. And she's amazing. She's brilliant. She's a powerhouse. She's like one of the most intelligent people you ever meet. So Regina started Wellcome Leap, which is an independent subsidiary of the Wellcome Trust, where the Wellcome Trust is one of the world's largest philanthropic organizations. So Wellcome Leap is basically to health what DARPA is to defense.
Wow.
But instead of being national, DARPA is within the United States. Wellcome Leap is global. So it's an agency that sponsors high risk, high reward research, but you got to move fast. So it's designed like DARPA. So every research program is a 3-year sprint.
Why do you have to move fast?
You got to move fast. You need to find out fast.
Yep.
They give you a ton of money. They give you autonomy. Yep. They work with you. They help you remove all sorts of blockers that we have in academia, that you have in the industry. They just really help you move fast because we have a problem. And we can't spend another 20 years just finding out if hormone therapy is important or helpful for Alzheimer's prevention. I need to know soon, right? Before I go through menopause. All of us, we need to know.
I get it, though. So what are you tasked with finding out right now?
Regina and I had a conversation, and I thought she wanted to give me money. I thought she wanted to give me a grant, right? And instead, she asked me to join Wellcome Leap as a program director, which is like Oppenheimer was the program director for that specific project. And that's how we ended up with the first ever global research program looking at menopause and neuroendocrine aging as a risk factor for Alzheimer's disease and whether or not hormone therapy can effectively reduce the risk of Alzheimer's disease for women. So Wellcome Leap devoted $50 million to my program, which is CARE. I so love the word care. It's very me.
Did you name it?
Yes.
You did?
Yes.
Oh, I didn't know that.
Yes.
That's
With
great.
Regina, we tried a lot of different words, and then I was like, how about CARE? So CARE stands for Cutting Alzheimer's Risk Through Endocrinology. Yeah, and also speaks to the fact that we should really start caring about women. Yeah. And for women, right? So it's a $50 million program of research. We launched in February, and we put out a call to other scientists all over the world to come work with us. And we got hundreds and hundreds of applications, so many more than I expected. And Leap moves really fast. So we had, I think, just 2 weeks to go through all the applications and select some to move forward to the next stage. And then there was a full proposal stage. And we just launched. We have 16 sites, including 64 leading scientists from all over the world. Actually, I'm going to show you. So this is our logo. This is for the kickoff meeting.
Alzheimer's at risk through endocrinology.
Yes.
That is amazing.
So CARE brings together 16 principal investigators, which is one person per site, and 48 multi-PIs and co-PIs, plus all their teams. So effectively, there's hundreds of individuals involved. And we have 3 different components to CARE. This is thrust 1, where we are developing biological neuroendocrine indicators of Alzheimer's risk for women. So CARE is 100% women. Actually, the vast majority of PIs are also women, which is really exciting.
That's exciting.
Yes, and you can see here where they are in the world.
We'll put a link to this if we're allowed to do that.
Yeah, I think so. But the most stunning data set is this. That all together, we're going to look at data. We're going to pull data from 122 international data sets from 6 continents, every continent except Antarctica, which I think has a reason to be. And we're going to look at biological data from over 30,000 women, imaged with brain scans at multiple time points for a total of over 100,000 data points. For context, the largest ever longitudinal study of menopause is mine, and we had like 40 women. We're going to have 100,000 data points.
Oh my gosh.
And also, if everything goes according to plan, we're going to have all sorts of clinical data from over 20 million women.
Can women get involved with this?
Yes.
Can any of us get involved with this?
Yes. So
you're going to tell us how we can do that?
Yes, I'm going to tell you how to do that. We have sites who are actively recruiting participants to become part of research, myself included, at Wellcome Medicine. My team is a site of CARE. And yes.
Dr. Mosconi, it's groundbreaking. You did so many groundbreaking studies already, but this is a groundbreaking study looking at something that we've never looked at, period, but on this level with this magnitude.
I'm so happy to be working with other scientists instead of being in some ways in financial competition with other scientists, because you're always trying to get money to do your own little research. And instead, this is an initiative, this is a collaboration. It starts out as a collaboration. And we all have proposals. We're all going to do the research. I'm going to be on top of the entire research I direct. This is effectively the largest ever global examination of women's risk of Alzheimer's ever attempted. What's really super interesting to me is that we are also going to address hormone therapy the ways we were just talking about it. So in a way that is statistically sound, statistically powered, that is well designed, and we're coming at it from all different angles. We have clinical trials of hormone therapy that looks not at Alzheimer's incidence 30 years from now, but it looks at markers of Alzheimer's in the brain. So we are going to measure directly the immediate impact of hormone therapy on biomarkers of Alzheimer's. We're going to do something called targeted trial emulation studies of hormone therapy using millions and millions of women. We're going to do like a precision medicine bioinformatic approach this question. We're going to use biological markers to look at risk of Alzheimer's in midlife women using the hormonal formulations that are prescribed today in clinical practices.
Do you think in 3 years?
Yes, I do actually.
That we're going to be changing the way we treat menopause?
Yes.
No
Hopefully.
question.
Well, I think we're going to have answers. I think what's happened is that we're looking at the same data over and over and over again.
What do you expect at the end of the 3 years to be able to do? I mean, I know you don't know the...
I can tell you what I want.
Tell me what you want.
I want 4 things to happen. So the first thing is that I want to know if hormone therapy can reduce the risk of Alzheimer's disease. And I'm quite confident we'll have really solid data. Then I want to be able to measure estrogen in the brain, because I think that we're not giving hormone therapy a fair chance, right? Because the way that the studies are done are indirect. We're using hormone therapy today, and the way that we're assessing whether it works or not is I either ask you if you're feeling better, which is statistically not awesome, or I measure your cognitive performance, where your cognitive performance, if it has changed, is changed by 1 point. I can't run statistics on that. Right? Or I wait 30 years.
Right.
To know if you're getting dementia, which is not obviously helpful to anyone. No. Or I can even measure biomarkers of Alzheimer's. But if I find a change, I don't know what's driving the change in the brain. So what we need is a tool that allows us to measure estrogen activity in the brain. And it's absolutely ridiculous that those tools have not been used.
What are the other two things?
So the other two things that I want is that we do know what kind of, well, I want estrogen imaging. I want brain estrogen imaging. I want a technique that is very accurate and that we can use in clinical practice and that will be used to measure whether hormone therapy does or doesn't do certain things in the brain. So I need a new technology that we're going to develop. And then number 3, when we look at risk factors for Alzheimer's, I'm sure you've heard that there are things that increase your risk of dementia. And there are 14 that have been formalized. So things like high blood pressure, high cholesterol levels, air pollution now, or diabetes, obesity, cardiovascular disease, some genetic factors. Those are recognized risk factors for Alzheimer's for men and women. There isn't a single female-specific factor being considered in those models. So we were, yes.
You want to know if it's menopause or perimenopause?
I want them in there.
Yes.
They have to be in there. And when the Lancet Commission published their last guidelines about Alzheimer's prevention, they did have a subsection about menopause as a possible risk factor, saying that more research is needed. But then they talked about hormone therapy, and they said that it increases the risk of dementia, especially for women who are going through surgical menopause. Whereas the research is showing the opposite, and clinical guidelines even are saying the hormone therapy can be protective for cognition for women who take it very close to surgery or in response to surgery. So that was...
We need to get that answer.
We need something called a population attributable risk, a PAR, for Alzheimer's disease that is specific to women. Because there are risk factors that may impact women more or less than men, right?
And we need to know what those
there are plenty of things that happen to women that don't happen to men. They have never been looked at. So we need to have a comprehensive risk assessment for women that we can then translate into predictive model. What I want is a risk calculator. I want which is part of care.
A risk calculator for Alzheimer's.
When you go to your doctor, the same way they were like, okay, let me check your cholesterol levels, let me check your blood pressure. Let me also check your risk of Alzheimer's and what factors may increase or diminish, which is important, your Alzheimer's risk. It could be as simple as an online calculator. We have it for cardiovascular disease. We have it for breast cancer. I want it for Alzheimer's. So, for instance, in 2024, we published the first large-scale study using a positron emission tomography technique, again, a PET technique with a ligand that binds to estrogen receptors in the brain. This was the first time ever that anyone used this technology successfully and applied it to women's brains, as far as I know at least, where we were able to get a strong signal with a difference according to menopausal status. So what we're looking at here is the way the estrogen binds to estrogen receptors in the brain, which is then what leads to energy levels and amyloid plaques reductions and neuroplasticity and whatnot. Do you see that red blob in the middle? That's the pituitary gland.
Yeah, we're looking at an image with a red big mark in the middle. Okay, pituitary gland. Which is that part of the brain that tells the ovaries to make estrogen and progesterone. And what all different models of menopause used to say until now was that the estrogen receptors would shut down after menopause, and they would only be active for a couple of years. Whereas we did this in women, because those studies are in rats. Right? Women are not rats. Our brains are much more complicated, and we outlive menopause, whereas rodents die soon after the end of their reproductive span. So what we have shown is that it's the opposite, that there are more estrogen receptors in women's brains as women's brains go through the menopause transition, so the perimenopausal and early postmenopausal stages, which means probably that either the brain is happy and is just compensating, right? There's less estrogen, so I need more receptors, or that the brain is not that happy and is putting out receptors
in a sort of starvation response.
Looking for more estrogen.
Looking for more estrogen, activating the pituitary to tell the ovaries, hello, we need estrogen here. We're leaning towards the second interpretation because women who had more estrogen receptors were also more likely to have memory issues and low mood. But we're looking into that. Now, this tracer is very specific for the pituitary gland.
Right.
It's not as sensitive for the rest of the brain. So what we're trying to do with care, which is necessary for clinical application. So this is good for research. It would not be for clinical practice. Also, it needs kinetic modeling, it needs all sorts of stuff to get the signal out. But for care, we're going to hopefully develop different tracers that are specific to brain estrogen, and they can give us all the information that we've been needing for hundreds of years.
So I'm not waiting for 3 years for you to come back on this podcast, but promise me that
as soon as I have data.
As soon as you have data, we can have you back on here with your brilliance. And as soon as you get a break from the research. Dr. Lisa Mosconi,
thank you.
Thank you so much.
Thank you for having me.
Thank you for what you're doing for the world.
Oh, thank you. Thank you all so much.
I don't know if I'm the only one who is so excited that the future of women's health is in the hands of scientists like Dr. Lisa Mosconi. What she's doing isn't just science, it's hope. It's proof that we're finally getting the answers we deserve and the tools to take care of our brains starting right now. If this conversation helped you, share it with a friend who needs to hear it. Hit subscribe, leave a review. I read all of them. Thank you so much for listening, and I'll see you next Wednesday. So today's episode is sponsored by MIDI Health. If you are ready to feel your best and write your second act script, visit joinmidi.com today to book your personalized insurance-covered virtual visit. That's joinmidi.com. MIDI, the care that women deserve.